to happen. And it's happened. So welcome everybody to this HIV Prevention England webinar on the importance of the undetectable equals untransmittable message, hashtag can't pass it on, where we're going to be having a particular focus on the impact of people living with HIV and the importance of clinicians or other people working with people living with HIV or at risk of HIV of sharing this message and getting this message out. It's over 5 years since the two seminal papers, Partner 1 and Partner 2, essentially kind of proved the case that people living with HIV who are on effective treatment have a zero risk of transmitting the virus to their sexual partners. It's over 5 years since Prevention and Access started their undetectable equals untransmittable U equals U campaign, which has grown into an incredibly impactful global movement. And we're going to hear from Bruce Richmond from Prevention and Access a little bit later. It's over 5 years since Terence Higgins Trust started our Can't Pass It On campaign. And whilst we've been working for many years to get the message out to people living with or at risk of HIV, we still have much more to do to get the message out to healthcare professionals, which is one of the key focuses of this session. So as well as learning about the evidence behind U equals U, understanding the importance of the message from a personal or patient's perspective, and starting to think about how we can raise the issue of U equals U, how we can discuss it with patients and give them confidence in the message, make sure they know about it, they understand it, and they have confidence in it. The other aim also is to introduce to you an online resource that Terence Higgins Trust has been working on over the last couple of years, slightly delayed by COVID, but now available online. We'll be sharing a link for that resource during the course of the webinar. I think everybody that's speaking on this webinar has contributed to that. Essentially, the resource is focused at healthcare professionals. It's a self-directed e-learning with a number of different modules with videos and contributions from a range of people. And most importantly, and I think most impactfully, and certainly my favorite bit of the web resource is the testimony of people living with HIV, speaking about the power and the importance of that message to them as individuals. Also, if you're somebody who knows about U equals U but wants to teach others about U equals U, there are downloadable resources such as PowerPoint presentations, FAQs, case studies that you can use to stimulate discussion. So have a look on that the website. You can search for it on the THT website, but we'll also be putting the link in the chat. Just the only bit of housekeeping I think I'm going to say is that we're really keen to include all of you in the discussions. So we really welcome questions for the panel, which you can put in the Q&A, or you can put it in the chat. We'll keep an eye on both. If you go to the bottom of your screen, you'll see the icons for Q&A and an icon for chat. We're going to probably try and save all of the questions to the end. We've saved 20, 25 minutes for Q&A at the end, and we'll store up your questions for the panel then. So I'm going to stop talking and hand over to our first speaker. It's a great pleasure and an honour to welcome Professor Alison Roger, who's a Professor of Infectious Diseases and HIV at University College in London, and most important amongst the wide range of her research outputs is she was the principal author on both the Partner 1 and Partner 2 studies. So welcome, Alison.
Thanks, Michael. Hi, everyone. Thanks very much for asking me. So I'm just going to try and share my slides. Is that working?
Yeah, we can see that.
Perfect. Sorry about that. Sorry, it's just I'm not great on Zoom. Right, thank you. Thanks very much, everyone, for asking me to talk today. So what I'm going to talk about is the science underpinning U equals U. So I've done this talk in various forums for about 4 years. And I think the reason I keep doing it is that it's U equals U is, to me, just the absolute pinnacle of communication. It's 3 symbols conveying about 20 years of research. But I think it's really important to understand how robust the evidence is so that when we talk to patients about this, we can be absolutely confident that the science underpinning this message is probably the most robust I've seen for anything. So we know what U equals U is. Sorry, my slide's moving. So a person living with HIV, undetectable viral load does not transmit HIV to the partners. That's an absolute, that's the scientifically established position. And it's quite unusual because science often is unable to prove a negative, but we are absolutely clear that this is the scientifically established position. There is zero risk. So we've been building this evidence around the U equals U message for about 2 decades. And we've known for ages that viral load is the single biggest determinant of HIV transmission risk. And that's not just sexually, that's you know, in utero to babies or through injecting drug use. And we know it's the biggest determinant, but the partner study that I was involved in was, I think, a tipping point in terms of our messaging around U equals U, that for sexual transmission, the risk is zero if you're on suppressive treatment. And I think Partner 2 really gave us the confidence to be definitive about the messaging and the languaging. That's really what today is about. It's being definitive about U equals U when we talk to people living with HIV. So the first thing I say to people who don't work in the field that maybe go, well, this is sort of slightly unusual concept, is that HIV transmission, even if you don't use a condom, even if you're living with HIV and you're not on treatment, and even if you don't use PEP or PrEP, it's quite uncommon. So the type of sex most associated with transmission, receptive anal sex, it's only about 14 per 1,000 times. So what you're doing is you're taking something that's generally uncommon and you're shifting it right down to the no risk end of the spectrum. So if you start from that position, it's often easier to understand why if you add ART in, you shift everything to zero. So this was the first evidence, 2000, it's 21 years ago now. So what you can see is this gradient of risk between the viral load of the person living with HIV and the risk of transmission to the negative partner. So it's quite clear across male to female, female to male, and for everyone. And in the 51 couples with a viral load less than 1,500, there was zero transmission. So that's really encouraging, but obviously the study was too small for us to be definitive about this. So there's a number of other smaller studies, and then we did a thing called a meta-analysis where you combine all the data from studies. And this looked at 11 different studies, all in heterosexual serodifferent couples, so one positive, one negative, and they got a 92% reduction in transmission with antiviral therapy. So that's amazing. That's a massive reduction, but it's not U equals U. And at the time, the WHO said there was insufficient evidence to promote this at the individual and population level. So this was 2009, just after the Swiss statement. So we kept going. And then we got this randomized controlled trial. And what they did was they took serodifferent couples and they randomized them to either start antiviral treatment immediately or to wait until the CD4 count fell below the guidelines of that era. And in 2011, their results were so staggering that the Data Safety Monitoring Board, who monitored the results throughout the study, basically said, you've got to stop this. You've got to give antiviral treatment to all positive partners because there's a massive reduction in risk of transmission. And so they did that and they kept going. And at the end, it was 93% lower, which again is fantastic, but it's not U equals U. But if you look at the 8 transmissions that happened, 4 of them happened from the positive partner to the negative partner in the first week that they were on treatment. So obviously viral load wasn't suppressed. And the other 4 happened often years later when positive people had, there were issues with treatment and they were failing treatment. So again, the viral load was not suppressed. So there was 100% reduction in transmission if the viral load was less than 200 copies. So that's the U equals U message. And that was in 2015. So you might think, don't we have enough evidence? You know, that was U equals U. There were no transmissions when it was less than 200 copies. We've really probably got enough. But we sort of thought, well, not quite enough. So the thing about HPTN was that there were very few gay serodifferent couples in there. In fact, only 2% of the full couples were gay men. And we thought, why should gay men have less level of evidence than people who have heterosexual sex? And in 052, people also use condoms, and we know that prevents HIV transmission. We were interested in what happens if you just use treatment alone. And the fact that we got zero transmissions is not the same as zero risk. So you have to be quite careful. You have to have very large studies so that you can really basically prove that the risk of transmission is zero. So we set up the partner studies, and this was a massive study, 75 European sites. It was an observational study because we didn't want to randomize people to use condoms or not. We recruited people, couples who'd chosen not to use condoms, and then we followed them up. And what we wanted to see was the risk of HIV transmission within partnerships when the positive partner was on suppressive treatment and they didn't use condoms. So I can talk a bit, I just put this slide up because I really want you to understand how robust the evidence is. We spent a long time designing this study. We wanted to be really sure of the answer. So we only included a couple years of follow-up in the final analysis. If they had condomless sex together, if they didn't use PEP and PrEP by the negative partner, and the viral load was less than 200 in the HIV positive partner. And then if a negative partner became positive, then we basically did sequencing of both viruses. And I'm not going to read this out, but it's well-established methodology because that tells you if it came from the positive partner on treatment or if it came from outside the relationship. So we were really careful in how we set this up. We wanted to get scientifically robust evidence. So at the end of partner one, and we presented this in 2014 and published in 2016. And overall, we 1,200 couples, or eligible couple years of follow-up, about a third from gay men. 11 of the negative partners became positive. By sequencing the viruses, we could say absolutely they did not come from the positive partner on treatment. And this was despite the couples having sex together 58,000 times without condoms. People had STIs during this, so this was a real life study. And if we look, I mean, Bruce calls it statistical origami, which I think is an amazing phrase, but when you do a research study, you want to be really sure of your estimate. So what we do is we do this thing about our confidence around the estimate. So even though we got 0 transmissions, we had to calculate how confident we were around that. And you can see for people that have heterosexual sex, it was much tighter than it was for gay men. And that translates into, for heterosexual couples, the absolute upper limit of risk, which was theoretical, was like 1 in 230 years of having condomless sex. But for gay men, it was about 1 in 80 years. That's still outside someone's sexual lifespan, possibly. But we just thought we need to be really sure of this. We need to give gay men the same level of evidence as heterosexual couples. So we kept going. And actually, when we published in JAMA Partner 1, it had a really quite conservative editorial. They basically said the risk wasn't 0, you needed more data, you needed more studies. So we knew we had to keep going. And it just was this, you know, when are you going to actually get off the fence? How much evidence do people need? So we kept going. The Opposites Attract study was an Australian study, Andrew Grulich, which reported, and again, 0 transmissions. And this, I think, is the final piece of the jigsaw. So this was Amsterdam, the World AIDS Conference 2018, and this is Matthew Hodson's quote. IES forever remembered as a conference when U equals U moved from an activist rallying call to the scientifically established position. And that was really with the partner 2 results. So by then we'd got about 1,600 couple years of follow-up just in gay men. 77,000 times these couples had sex without condoms and 0 linked transmissions. So 15 of the negative partners became positive, but we know by sequencing it did not come from their positive partner. And that was despite quite high levels of STIs in both partners. So that was it. I'm not going to go through the phylogenetic tree because we don't have time. But if you look at where we were after partner 1, and then you look at where we are after partner 2, you can see what we've shifted. We are incredibly sure of this result. In fact, you'd have to have the absolute upper limit of risk, which again is theoretical, is you'd have to have condomless sex for 450 years before you do an outside possibility. It's impossible. So the risk is 0. And I think we have to look at the evidence. So there's been a lot of really well-designed, very large studies which have looked at this question. And we tried really hard to find a transmission, really, really hard, and we didn't find one. And by contrast, there are 0 studies which show that you can transmit if you're on suppressive ART. So there's 0 risk of HIV transmission through sex with suppressed viral load. That is the definitive answer. And I'm not sure we've got time, but just the yes, but. So people, when I present this data, people come back with, what about if people have viral load blips? And the reason we chose less than 200 copies is that viral load blips don't matter. People have them periodically, they resuppress. As long as you're less than 200 copies, U equals U applies. And people talk about as well, you're only as good as your last viral load. Well, you're actually as good as your last viral load because past predicts future. And if you are able to keep taking your medication, you will remain suppressed. U equals U applies. STIs do not increase the risk of transmission. We know this from all the studies that have been done. We had a lot of STIs amongst people that took part in partner 1 and 2, 0 transmissions. And this whole issue about genital shedding, we know it happens if you're on suppressive ART, but the low levels that you find, it's replication deficient. You cannot grow it in the lab. You cannot transmit. And we know that it happened in partner 1 and partner 2. CDC have given 100% effectiveness if you take ART daily in preventing transmission. That's how confident everybody is about U equals U. And I think this is why U equals U is important. Bruce will go into this in much better detail, and he talks about it much better than I, but it's not just about transmission. It's about removing the shame and fear and stigma from HIV. And I think that is really the key, and it's something we'll talk about later. It's trying to get the message out into the general population as well to destigmatize HIV. And I think, you know, I love this quote as well. Somebody, after you'd spoken to them, Bruce, this is what they said about U equals U, about how they felt it made them feel. And I think it was a lovely quote about the impact on someone about U equals U. So I think final message, I think scientists were trained to be really cautious. We need to be convinced by the evidence. And I think it took a long time to build the evidence for U equals U to develop, but it's now accepted by all the leading health organizations, all the world's leading scientists, all the organizations. We all strongly support U equals U. And I think there's zero risk, and there's now zero excuses for not fully accepting this, for not having the confidence to accept it. And the final thing I'd say is it's not up to us to place any moral value on data. It's up to us to translate the data and be confident about the data to improve the lives of people living with HIV. So a huge thanks to everyone that took part in the partner studies, and thanks to you for listening. Thank you.
Thank you very much, Alison. Perfectly kept time and beautifully presented as always. Now, as we go along, I'm going to encourage people to put questions into the chat or use the Q&A function at the bottom of the screen, and we'll try and pull things together, and we'll pull things together and bring them to the panel for the Q&A at the end. Although I can see, and we do have a minute or two, that Vicky, you have your hand up, so if you'd like to ask a question, I think you should be able to. Vicky, I think you're on mute. Okay, and all your hands gone down, so don't worry. Apologies if that was a mistake and I came to you when you didn't want to ask a question. If you do have a question though, do put it in the chat or in the Q&A, and we'll collate those for the panel at the end. So moving on, Alison has nicely led us into the next section on the agenda by talking about the importance of the voices of people living with HIV in this work. So it's a great pleasure to welcome three great speakers, all of whom can be seen on our web-based e-learning resource, which I will continue to promote until you're sick of me hearing about it, and we will be putting the link for that in the chat, who we are going to go in alphabetical order, because that seemed like the fairest way to do it. So Dean, welcome. You have the floor and the microphone.
Thank you very much. Hello everyone. My name is Dean. I think I found out I was HIV positive in 2013 or 14. Admittedly, my knowledge of it was fairly low. I'd had an incident which I'd mentioned on the video we were just talking about, when I'd had to use PEP, and I'd asked someone if they had anything, and they told me they were positive, and I freaked out. I was quite nasty to him. I was very bitter about it, and massively regret it now, because he said, "No, it's fine. You can't pass it on." But I felt like a victim. I felt like I thought like it was. I thought it was illegal. And I think for the years I'd been sexually active, and one particular incident sticks out when I was at university, and a nurse or practitioner said to me, "It's not a question of if you get HIV, it's a question of when." And she was kind of trying to be a bit blunt about my risky behaviours, so to speak. And I don't think obviously back then the U equals U wasn't necessarily a thing, but when I was at university, because that was in 2011, I think. But when I had that incident with the gent that was positive, I was completely unaware. Whether that's my fault or whatever, I'm not sure. But I just think, had I been aware of that prior, I wouldn't have been as. Had I taken the time to educate myself about it, or if someone had not forced it down my throat, if I'd been made a bit more aware about it a bit sooner, I probably wouldn't have responded to him the way that I did. When I was actually told that I was positive, aside from making a number of really inappropriate jokes, I remember it was quite a while before I was told about the whole undetectable U=U type thing. And my first thoughts when I was told was, I'm never going to have sex again, I'm going to pass it on. And I felt very alien. And it took quite a long time for me to accept that. So I think for me personally, I wish that it was just shoved down my throat a bit more. I feel like I would have benefited from being able to psychologically deal with being told that news if I didn't feel as alien as I did. You know, and save maybe 3 or 4 incidences over the last 7 or 8 years, I've never had an issue with it as a gay man in London. I tell people that I'm positive fairly quickly. I've trivialized it to the extent that I've actually named it Nancy. Don't know why. But I tell people about it very soon. And 99% of the time, by gay men at least, I'm met with, all right, whatever. Which for me is just, it's such a blessing, because in comparison to when I first found out, I thought I was never going to have sex again. I felt alien. I felt infected. I felt like I was I honestly didn't think I was ever going to be able to sustain a relationship unless it was with another positive person. And the whole U=U thing, it's such a game changer for me, at least. I think I'm very fortunate to have not to have got it, but to have got it in a time where I can be open about it. I've told everyone at work, and as I was saying earlier, I'm a police officer. I've told people at work. That's a bit more of an uphill challenge to try and educate people where it's not in their, it's not in their periphery. I'm not sure, but yeah, I've been met with nothing but positivity and support. And I've not felt, again, like I said, save 1 or 2 times where I've had to educate people a little bit, sometimes sternly. But yeah, I've been met with nothing but, acceptance. And I think that is, had I been born 10, 15, 20 years earlier, it would have been completely different. So I feel very fortunate. But yeah, I do wish that I'd been educated a bit more, a bit earlier. I think that's about what I've got to say about it. I'm not sure how much time is.
You've timed it perfectly, Dean. Thank you.
Lovely.
And thank you for sharing your story. And thank you for joining this webinar. I don't know if you mind me telling people that you're unfortunately locked out at the moment, which is why Dean's in an open space, and thankfully the rain is staying away. You've got a brolly. Were you a Boy Scout by any chance? Always be prepared. So thank you very much, Dean, for sharing your story. And all of our participants, as I said, are very happy to answer any questions, whether they're general questions about the science or individual questions about their experience. And as we've said, you can hear more of Dean's story on our web-based resource for learning about U=U, and I put a link for that in the chat. So it's now a great pleasure to welcome Estelle, who's going to share her story. Thanks for joining us, Estelle.
Thank you so much, Michael, and thank you so much, Dean, for your story. Different. I was living with HIV now for 2 decades. I was diagnosed in the late 90s, like Dean. So at that time, U=U messaging wasn't something that we saw anywhere in the clinic. It wasn't mentioned as much. We were really, I was diagnosed very late. So I had an AIDS diagnosis when I had TB. So it has been a journey for me. For me, just being in this era of U=U is life-changing for me. Just being able, I felt like shackles were removed from my whole being. Just freedom, a sense of freedom. Because growing up with a lot of self-stigma, a lot of feeling like you're not worth, if you're diagnosed late, you grow up with with a sense of, not worthy. So my journey has been, I've really truly embraced this U=U messaging. 2 decades on, I'm here, and I'm an educator, a peer support. I give people peer support And to me, it has given me hope. Hope that there is a future. And the biggest hope I have is I believe that the cure is around the corner somewhere. I have that belief. And it also helped me a lot in terms of adherence, because I did struggle with adherence in my 2 decades journey. There was times I just didn't want to take medication. I just gave up. I thought, oh, it's 10 years now, I'm still taking medication. But when this messaging of you is equals to you came about, I was like, no, really? Yeah, okay. So that really did help me a lot in terms of keeping in check with my medication and knowing that I'm not going to miss my medication. I'm not going to play around with not taking or, not being able to take my medication. And also, why is you is equals to you important? The messaging of you is equals to you. I am a peer mentor and a mother mentor. So this messaging is so important, especially when we are mentoring newly diagnosed moms or newly diagnosed, anybody being newly diagnosed. It's a really difficult time. So when we come in and just encourage them, like, there is hope. You just take your medication. I have been with this thing 20 years. I'm still here. I was diagnosed 20 years ago. I had a full-blown AIDS. I was 40 kilograms. I'm still here. There's a lot of hope. So this messaging of you is equals to you makes my work a little bit easier. And I make a lot of difference in many people's life. And I think I'll answer the last question. It was for the doctors. Why is it important for the doctors to know about you is equals to you? I think it's very important for the doctors to know because I'll just give a story. I had a major surgery in 2019 in a London hospital. I won't mention which one. And in my file, they had put, I had a very high viral load. So, and every day I kept discussing this to the nurses that came to see me. I said, it's not high viral load, I have a high CD4 count, but that wasn't changed. So, just thinking like this is a big hospital with all these big doctors, that messaging can be taken really differently. And as I was having this major surgery with that kind of information in my file, it could have changed so many things. So, so just like, I think you is equals to you message need to be, when we're having our blood test, there's in any room, when you see all these stickers that are stuck in all the GP's room, no smoking, family planning, you is equals to you messaging need to be there. That messaging need to be there so that people can really start asking questions about what it really means. And I think that's about it for me.
Thank you, Estelle. Wonderful, powerful, and perfectly kept time as well. And thank you for sharing your story and for all the really important work you do as a peer mentor and as a mother mentor. Those are really important roles, and it's good to hear how it's supported you in your adherence and also supported you to do the work that you do for others. So thank you. So we will now move on to hear from Sue, who I want us all to welcome and wish a very happy birthday. Sue is talking to us on her birthday, so we're really grateful, Sue, for you giving up some of your time this evening, and I hope you're getting a chance to celebrate after we've finished. So welcome, Sue, and over to you.
Thank you. And you know what, that just proves commitment and passion, doesn't it, really? And I am a woman living with HIV. I have been for the last, coming on to my 17th year. And when I was diagnosed, of course, HIV doesn't happen to white heterosexual women, does it? That's the culture I was born into. That's how I was educated from family and schooling. So it was quite a massive learning when I was first diagnosed, because I said to myself, how did I possibly contract HIV? But through that own self-learning and education, I found out how I acquired HIV from unprotected sex. So that was a massive game changer to start. So, as I say, living with HIV 16 years, U equals U was sort of in the background. There was things about can't pass it on. It was just echoes. But obviously now, when I first learned about U equals U, I'm thinking, okay, we've got to talk about future generations, haven't we? We've got to educate the next generation on how to look after themselves. And we're only going to do that if we've got scientific evidence to say that if you were to contract HIV, you can have a normal life expectancy. And we have to have the data and the information and education for that. I do a lot of work in schools to educate young people to look after their own sexual health and to create HIV awareness. And the message of can't pass it on and U equals U is absolutely key, because to get a young person to test for HIV, we need evidence, we need information to say that it's really in your interest to go and get a HIV test, because if it was that you were to become positive, you'll take your medication. You can do anything. I mean, and that speaks volumes to a young person. But on a personal level, I honestly think knowing that I cannot pass my virus on to another sexual partner, it keeps my mental health well-being up here, because I know I can't pass that virus on. And knowing that my healthcare professions know that message as well, because that gives me confidence that when I go and see my GP, they know about U equals U. So I can completely open up. I can say all the things perhaps I might have not wanted to talk to my GP about. I mean, hey, going back a few years, I remember going to see my GP some years ago. It was for a ladies thing. I can't remember what it was. And I remember sitting there with my GP, and I'd made that decision to share my status on my records. I'm all for looking after my health. And I hadn't seen this particular doctor before. When you see my records, he said, "Oh, so you've got HIV?" I said, "Oh, yes, doctor." And he turned around to me and he said, "Where did you get that from?" Now, I am absolutely sure he did not mean to say that. I have trust and confidence in our fantastic National Health Service. And I just quite politely said to him, "From unprotected sex, doctor." And then, you know, perhaps that particular doctor didn't know about U equals U. And, you know, what amazing it would be if he does now know about U equals U, because if I'd been a different person, I could have gone home, closed the doors, close the windows, close the shutters and not come out again. But because I had a platform where I talk about HIV, I was able to control it, think about it, think, okay, we need to speak to doctors and nurses and people coming into the medical profession. So, but U equals U is, like the other speakers have said, it is a game changer, not just necessarily for people living with HIV, but for future generations, to encourage them to test and to give them answers why they should test, to say that their life will be okay, because we've got scientific evidence to say that if you have HIV, you will not pass it on. Now, you know, women can have children and not pass HIV on to their unborn children. This is the messages we talk to young people about, which is absolutely crucial if we want to end HIV transmission and have a world where we eradicate stigma. So U equals U. And I'm so happy that I'm attending, even on my birthday, because, you know, we're talking about the future of HIV here. We're talking about banging down that stigma and discrimination. And we have scientific evidence now to say, here it is. There's no need, there's no worry, test for HIV, make it like you would test for chlamydia, because if it was to come back that you were positive, you can take one pill a day. I take one pill a day, and I know that one pill makes sure that I do not pass that virus on to someone else. So, you know, U equals U. So great to be part of all things like this, and, you know, to work for an amazing charity. And you know, my passion, as you can see, is educating the next generation. I have a daughter, she's 24 now, and I kept a secret of shame and not wanting to tell her, because I thought I was going to die because of the virus. I was unsure about it at the time, and I kept a secret for years until I eventually made the courage to talk to her. And the first thing she said to me, "You're going to die, aren't you, Mum? You're going to die." And now I'll say, "Well, I'm still here." And that's because I've been able to tell her the messages that if she was to get, thank God she doesn't, if she was to acquire the virus, the medication will stop her from passing it on. She says those messages also to her friends as well. So U=U is an absolute key to future generations of education. Thank you.
Thank you, Sue. Again, thank you for sharing your story. Your passion is self-evident, and thanks for all that you do to share that message with the work that you do. So thank you very much. So keep sending in any questions. I can see one or two coming through. We're going to store them up and bring them to the panel at the end. We'll be inviting all of the speakers back to the panel, so you can ask general questions or ask questions specific of any particular panelist, or just put your thoughts or comments in the chat, as Tom has kindly done. Thanks to Dean, Estelle and Sue for sharing your stories and lived experience. So awesome and powerful to hear from all of you, and many happy returns to Sue. I think we all share that message. So we're going to move on now. I mean, as I've said, and as pretty much all of our speakers, certainly our last three speakers have highlighted, that this is a really powerful and important message that is still not fully understood or known outside of HIV healthcare professionals. There was a survey that was done in North East London hospitals, so not primary care, but hospital settings, asking about the knowledge around U=U of non-HIV healthcare professionals, doctors and nurses, and about 20% of the respondents, about 500 respondents, had heard of U=U, and that's about the same level that we get when we do similar surveys in the general population. So we've got a lot to do to communicate this message out to healthcare professionals. And on that note, it's a pleasure to welcome Dr. Mel Gardner, who you can also see on our amazing e-learning resource, the link for which is in the chat. Mel's going to be talking about how to talk about the U=U message and can't pass it on, with a particular focus on the primary care setting. Mel is a GP and a director of the social enterprise Sexual Health in Practice, or SHIP, that does a lot of training for GPs, particularly around issues of HIV and sexual health. And Mel is also somebody who has very generously given up her time at conferences. I'm mentioning this, Mel's currently on maternity leave, so congratulations on your newborn, and well done for looking so good on it.
Thank you. Okay, I'll just get my slides up, everyone. There we go. Right, so yeah, it's thank you for inviting me. It's really a pleasure to be here to talk about this. And yeah, as Michael said, I'm going to be talking about this really from a primary care perspective. I mean, we've seen from the previous speakers, there is just such clear, overwhelming evidence that U=U. And then we've heard about the transformative impact that message has to patients. Our patients, you know, I'm talking to people here as if you're GPs, but you know, if you're not, hopefully you can see the relevance of this. And so just over the next sort of few slides, I just want to cover these 3 points really. So how we can bring up U=U with our patients who are living with HIV, and why that's important. 2, discussing U=U when we're offering an HIV test. So that's for patients who don't know their HIV status, and when we're talking about sort of increasing testing and offering testing, why U=U is so important to mention at that point, and also how we can spread the message in other ways. So first of all, bringing up our patient, bringing up this concept, this information with our patients who are living with HIV. I think that this is really important because we might be letting these patients know for the first time. I mean, if they're well established and attending, you know, their clinic, their specialist clinic, we probably won't be telling them for the first time. But you know, we may come across someone and we've sort of pick this up from the notes and we mention it, and actually it might be the very first time they've heard about it, and I think that's incredibly important, so we can kind of signpost and you know, and have a wider discussion. It might be that we're reinforcing the message, and I think it's really important for people to hear this message from different healthcare providers, and particularly their GP, where you have a special relationship with the patients, and that's obviously not going to be the case with all of our patients, but there's certainly a few patients who only want to consult with me, and it's not that my colleagues aren't as good and as competent as me, but they just have a relationship with me, and so certain things kind of are heard in a different way. So I think reinforcing this message is really important with patients, particularly where we have a relationship. And also, I think it contributes to the normalization of treating HIV as any other long-term condition. So we're just going to talk about it. We're going to see how you're doing. Are you going to clinic? Are there any issues? And did you know about this this, well, not new, but, did you know about this, this key piece of information about treatment and how it impacts HIV as a disease? So I think it's helpful wherever the patient is on their journey with knowing about U equals U. So here are just some suggestions, and this is the sort of thing that we do all the time because we're always bringing up things opportunistically in primary care, whether that's sort of mentioning smears or asking people about smoking because the QOF boxes need to be ticked. So here's a phrase you could try while you're here or while I've got you on the phone. Do you mind if we take a few minutes to talk about how you're getting on with your HIV at the moment? So just kind of to introduce the topic and just sort of segue from whatever that person has consulted about into saying, actually, let's talk about your chronic condition, much like you would with other chronic conditions. Or I'm glad you're here, or I'm glad I've got you on the phone, as I've been meaning to ask you about your HIV care. And so that's phrases that we probably use for other things all of the time, and I think it's just important to bring it up in that way. And then we can ask, if we don't know from clinic letters, if we haven't got the latest ones, or just as a way again of kind of deepening the conversation, how is your HIV control? How's your viral load? How's it been recently? Have you heard or seen anything to do with U equals U or can't pass it on campaigns? That's a nice way of kind of just seeing where the patient's at in terms of knowing about this message. And we can then categorically kind of move into saying something like, I can see from your records that your viral load has been fully suppressed for some time, which is great. So I wanted to be sure that you were aware that this means that you cannot pass on HIV to your sexual partners. So, these sorts of phrases are kind of bringing their HIV up as a long-term condition, as you would with other long-term conditions, as opportunistically, and then actually getting into the point where we're telling them about the evidence. Just a kind of an aside thing, and maybe we can chat more about this at the end if anyone's got questions. But actually, I'm really sort of in our teaching with SHIP, we're really trying to promote the idea of an annual primary care review of patients. So not to say that the patients are not under the specialists, of course they are, and they need the specialists to do all the clever things with the medications and other stuff that they do. But actually there's a lot of primary care, bread and butter primary care that patients and people living with HIV kind of could definitely benefit from, such as management of cardiovascular risk, annual flu jab, annual cervical screening, which not everyone is aware of, that it's annual rather than every 3 or 5 years. Considering other psychosocial aspects of having a long-term condition such as anxiety and depression, and doing what we're very good at in primary care, which is kind of supporting people around lifestyle changes and signposting and guided self-help and that sort of thing. So now I'm just going to move on to discussing U equals U when we're offering an HIV test. I think this makes it much easier to offer HIV tests because actually some people might be very frightened about knowing their HIV status because they feel that, or they've heard that HIV equals death, and actually they just don't want to know. So I think I wouldn't necessarily say this to, I think with sometimes you're offering an HIV test and it's easily accepted, and it's sort of part of a battery of tests that you're doing, and that's great. But particularly if someone's a bit anxious about it or seems a bit reticent, I think it's really important to mention the message. So it's well worth knowing if you have HIV, because you can't pass it on if you're taking a medication and your viral load is undetectable. So that's the sort of phrase that you might use. And just to mention at this point, there are different indications for testing for HIV in primary care. So if you've sort of discovered that someone's has had a sexual health risk after sort of doing a rapid risk assessment of their sexual health, then of course we'd be offering an HIV test in that context. But also, I think it's a lesser known piece of information from the sort of teaching I've done, really, that we should be offering HIV tests to all patients who are newly registering in our practices in high prevalence areas. And that's where the prevalence is over 2 per 1,000 people aged 15 to 59 years old. That is all London boroughs, and also other major cities in the UK will be high prevalence. So if you're working in London as a GP, then all newly registered patients should be offered an HIV test according to our national guidance. So it's well worth doing. And for patients unwilling to test, you could use phrases like this: we're trying to do a lot more HIV testing because it responds so well to treatment. In fact, the treatment is so fantastic that if you take it regularly, we now know you can't pass HIV on to anyone else or to your sexual partners. And it's always better to know than not to know. So I would always say, if in doubt, get tested. So these are some sort of phrases that you can kind of use to add to your repertoire when we're talking about it, and to just feel confident saying these things. And very briefly, just one slide on how we can spread the message in other ways. So with patients, I think it's important for this to sort of be visible in the practice. So there are posters that you can download from the resource that Michael's already kind of pointed out, that we can put in the reception area or in the clinical room. We've got PowerPoint, that THT have got PowerPoint slides as well for screens in reception, so you can sort of advertise the U=U message there. And if you've got a practice newsletter or even a Twitter account or anything like that, you can sort of post on that or add a little article for that. I think it's the sort of thing that's really interesting for colleagues to hear about. So you may want to do a clinical meeting on this, and again, there are resources to help you if you feel you do want to sort of have a discussion around this in a formal clinical meeting, or more informally, just at a coffee break. Say, have you heard of this? Because I haven't heard of this before. That sort of thing, spreading the message. And directing colleagues to the website, and particularly trainees as well. Trainees really, really have, we've had great feedback from trainees about this resource, and it's something that even though they are, learning medicine, have gone through medical school relatively recently, it's still not something that they're particularly sure of necessarily. And if you're the type, I'm not particularly social media savvy, but if you are, then of course, sort of sharing the message on social media as well. So I'll just stop sharing there. There we go. So I mean, I think there's a huge spectrum of where people are with clinicians in terms of their knowledge around HIV generally, and because how the disease has transformed over the last sort of 40 years from being something so fatal to being something so treatable and preventable. And I just sort of, while I was listening to others speak, I remembered someone in the last teaching session I did who, I think it was a practice nurse who just said, well, we had this government campaign. I remember the Tombstone campaign in the 80s about how sort of deathly HIV is. Where is the TV government campaign reversing that message? Like, where is that? Because I didn't know any of this. And I said, we're that message. That's us. That is the point about this, because we're not going to get that big TV campaign with reversing the tombstones or however it would be. It's about us, and it's about our day-to-day interactions, our conversations, and sort of also how we present information to patients, just as we would with any other condition. Thank you.
Thank you, Mel. Perfect. Really, really helpful practical tips, which are relevant not just for primary care, obviously primary care is such an important area to be getting this message out, but practical tips that people can use in other settings. And as Mel has said, you can download resources to support that, posters, PowerPoint slides from the resource online. And I think my colleague George has put the link for those resources into the chat. So I can see the questions coming through. So thank you very much for those who've submitted questions. We will come to those when we bring the panel together shortly, and keep the questions coming if you have any. But now it's a great pleasure to hand over to the main event, if you like. We will be warming up towards the amazing Bruce Richmond, who's going to talk about U=U as a game changer in the more global context. I'll leave Bruce to introduce himself, but just to say that undetectable equal untransmittable, the U equals U campaign pretty much started from Bruce's flat in New York. He's the powerhouse activist behind what is now a huge global movement. So without further ado, I'm going to hand over to Bruce.
Thank you, Michael. Can you see my screen okay?
Yep.
Okay, I'm going to be gushing about you in a couple minutes too. So I'm just incredibly excited to share with everyone what we did together. This movement is tremendous. It's on every continent. And I'm just going to be able to give you a glimpse of what's happening around the world and where we're going. A lot of this information is actually new since the HCP training. I was a part of that, very lucky to be a part of that really helpful resource for HCPs. So I am the founding executive director of Prevention Access Campaign, and why did we start U equals U? What were our first goals when we organized with activists and researchers and public health officials? First, this was to build a global consensus on U equals U, and I think that we pretty much did this working inside and outside the medical scientific establishment. This is a fact. Done. And then number two is to disseminate that, communicate that through a network of partners who can adapt U equals U for the communities that they serve, so it's culturally and appropriate. And then finally, this is really important, and we're in number 2 and number 3 right now, is to communicate and to make sure that we use U equals U in our advocacy so that everyone who has HIV can have the opportunity to experience it. And we're using that now as what we call a public health argument for access to care. And I'm going to explain that in a minute. So why is this so important? We heard, I was diagnosed 20 years ago, and really related to what we heard from Dean and Estelle and Sue earlier. This changes our social lives, our sexual lives, our reproductive lives, and that should be enough to shout this from the rooftops, the way that it changes our lives. But it also reduces the stigma that we faced, and that the stigma is the greatest challenge to ending the epidemic in so many ways, as we heard earlier. And this is aligned with our treatment goals, the 95, 95, 95 targets. It increases testing rates. It is an incentive to start treatment and stay on treatment and stay in care, to be virally suppressed for our health and to prevent passing on to our partners. We're seeing this modernizing discriminatory laws, policies, and practices, the criminalization of HIV non-disclosure, reforming policies on serving in the military in the UK, and no longer restricting the advancement of military members in the United States. Recently in Dubai, the Ministry of Oman talked about how previously people with HIV were denied marriage licenses. They had compulsory tests. And now when someone with HIV is undetectable for a year or more, they can get married, they can get a license. Now that's incremental change. No one living with HIV, regardless of viral load, should be denied a marriage license, but it's really incremental, an important step in that region because of the U equals U activists in that region. And finally, this is the call for universal access, which I'm going to explain now in more depth. So this is an incredibly exciting time for people with HIV, because those things that keep us healthy, so increasing the access to treatment and reducing those barriers to care to keep us healthy and undetectable, is good for personal health and public health. It's good for us and the community. So now in our advocacy, we can say, investing in us as people living with HIV is a win-win for everyone. And this is the key to ending the epidemic. And this also gets around the racism, the transphobia, and the homophobia, because even if you don't like me and you're prejudiced against me because I'm gay and you're serophobic and you're devaluing my life as someone with HIV, still, U equals U is the foundation of ending the epidemic, and you need to get us treatment and care so that we live and we prevent the spread of HIV to anyone. So why do we start this? Well, with the exception of the Swiss statement back in 2016, nobody was saying this. And it's so important to get this message out, but the aggregate of science didn't have a publicist. So we had to become the publicists. And there was an urgency around this. We couldn't wait, because we knew that HIV stigma is an emergency. People were suffering, and they're suffering right now still. As we heard earlier, it's so pervasive. And U equals U is an immediate and effective response. So we felt there was no time to waste. We need to get this message out. Every time the risk was exaggerated about our lives, that put our lives at risk. And it continues to put our life at risk. So fortunately, there were people who agreed with us all over the world. And some of them risked their personal and professional reputations to be the first to speak out in their countries, in their communities, and in the world. And one such person is here today, actually two, we'll talk about, and that is Michael Brady. When we saw this campaign in August of 2016, just as we launched U equals U, this was a gold mine for us, because we could use this. This was the first message from a medical director and a majorly established organization to confirm U equals U. So we would use this and go to the US government, other governments, lots and lots of organizations in the United States, Canada, and elsewhere, and say, look what they're doing in the UK. Look what they're saying there. We need to say it here too. We must say it here. So Michael, you are such a hero in this, and can't say enough how much Terence Higgins Trust, Michael and Ian Green's, their leadership. I mean, if this was, you could have been wrong, right? You took a real risk, so thank you. So where are we now today? Because of this incredible collaboration between activists and scientists, and the campaign is in 105 countries. That's more than half the countries in the world at this point. And it's very exciting because we've got this strength from the top down and the bottom up. And we've got endorsements from the most influential organizations in our field and in global health. And we have a very united, very passionate force of activists around the world. And it's still not a very well-known movement. A lot of people just think U equals U happened, but it didn't happen on its own. It was a movement. PEPFAR is endorsing U equals U as one of 16 minimum requirements. And it's also highlighting U equals U under primary and people-centered prevention. So it's so important to say that, look, getting people treatment and care is also primary prevention. That's the key to epidemic control. So again, it's a very exciting time for people with HIV to demand what we need to stay healthy, because it's a win for everyone. Very important. Just last week, the CDC got rid of that term effectively. I saw in the Q&A, someone asked if we needed to use the term effectively. No, we don't. They used to say effectively no risk. You're going to see that phased out of all of the CDC's communications over the next couple of weeks. So they're being very clear with their language and using U equals U and hashtag U equals U. And the CDC, I'm pointing out, because the CDC has influence all over the world. When I was in the Middle East, almost every presenter referred to the CDC's information, a description of risk. So this is really important. And as Allison said earlier, the CDC is estimating that viral suppression, or U equals U, is 100% effective for sexual transmission. And what's so exciting is, as you've seen, these agencies are now promoting it. They're getting it out on social media. They're creating campaigns about it. They're not just making statements. They're actually educating the public. And U equals U is in the top 3 medical journals of the world. So we're seeing researchers and journalists talk about it and write about it. U equals U is the focus of regional conferences. This was one of the best presentations I've ever seen on U equals U from a doctor from the Saudi Arabia Ministry of Health. U equals U is a war between ignorance and knowledge. It was incredible. Also in the India's recent national conference, U equals U was the main message of the conference. It was on every single bag. And this was the message in the beginning, is that if we can make U equals U available to everyone living with HIV, we can end the epidemic. We can save lives and end the epidemic. And again, that's this beautiful win-win approach that now we really need to invest in people with HIV. And Japan, I was so excited to be able to speak in Japan. In several cities in Japan. China's U equals U conference was phenomenal and led by young people, by Jeff Kong from Love to Love organization and Beijing Love Without Borders. There have been national conferences. You can see Alison and Valerie Delpash from Public Health England and I speaking at the Russian National Pro-HIV Conference, and then there's also a Stigma and Discrimination Conference. And I just want to spend a minute and mention the very important campaign in the Ukraine. There's a government-funded national H=H campaign. I mean, we don't even have that yet in the United States. And we're seeing this in countries around the world, in the Ukraine, and we really support them. This is a teen program on the right called Teenergizer. Just want to support our partners in Ukraine, the U=U partner organization, formerly the All Ukrainian Network of People with HIV, 100% Life. Many of them have stayed in Ukraine to provide support to people with HIV and set up emergency shelters and get medical attention. And so I really want to support them. I'm going to show their website later. National campaigns in Zambia, Kenya, and Vietnam. Again, these are government-funded programs. And by the way, that's the former president of Zambia with the U=U shirt. We're seeing so much creativity. This is from England and Spain. We're seeing U=U in gardens. We're seeing U=U street posters and graffiti in Italy and Argentina. Italy, I love this one, the U=U, the revolution that wasn't televised but happened. I love that because, again, a lot of people don't know this actually happened because of this movement. And so many people made this U=U what it is today. More street art in Ireland and performance art in Ireland. U=U food and fashion from England, Botswana, and Australia. And this was really cool, a U=U augmented reality coffee cup that we worked on with Terence Higgins Trush, Bash, and Biva and Gilead in the UK, that many of you may have gotten this email to 25,000 HCPs. And this is just fun. I want to show you this from Ireland, Vietnam, and Argentina. Young people have been incredible with this campaign. And we've got to get this message out. There's really no excuses. All over the world, people are standing up and joining with people, with researchers and public health officials. And I would like to share the words of Alison Roger at one of the most pivotal moments of my life and the pivotal moment of the campaign, when, as Matthew Hodson said, this is the time when U=U became institutionalized. And here Alison says it perfectly when I asked her, what would you say to healthcare providers who are withholding this information?
I think the time for excuses are over. I think it's very, very clear that the risk is zero. So I very much think we have to promote this. I think if you're on suppressive ART, you're sexually non-infectious, and yeah, the time for excuses is over. And I again pay tribute to you and your work. Thank you.
Well said. Thank you, Alison.
That always gets us emotional. I have cried with people with HIV from New Zealand to Japan, Australia, Switzerland, seeing this message. In Italy, we get very emotional because we're seeing someone who is so prestigious and important in this field clearly and unequivocally say the risk is zero and call for people all over to promote this in front of thousands of her peers. So thank you so much, Alison. This was absolutely pivotal moment. And as you can see, this phrase, zero risk, zero excuses, has been picked up everywhere. This is a march in Kampala, Uganda. So this is really our time as people with HIV to demand what we need, because now we know we can live and we can love without passing on HIV, and getting the U=U is not only good for us, but it's essential for ending the epidemic. This is our rallying cry to get what we need, get the treatment, care, and the services. And so here's how we can all join the movement. This is what our call is, and generally for healthcare providers, but also for everyone. First, we need to make sure that U=U is integrated into the national guidelines, policies, laws, strategies. And as I mentioned, we've seen it in Kenya, Vietnam, Zambia, and the United States guidelines have been updated. Public Health England was one of the first to update their guidelines. We need to educate like we're doing today, have these dialogues with healthcare providers and with people with HIV at every opportunity. We need to promote it, U=U, clearly, confidently, consciously, and consistently, repeatedly promote it. Can't pass it on in any way that people will understand. repeatedly. Change is uncomfortable. Excuse me. So this has to be continually repeated. And finally, last but not least, we need to increase the access and remove barriers to care so that all people living with HIV can have lives, healthy, happy lives without any fear of passing on the virus. Finally. Thank you so much. Really appreciate this opportunity. There are a lot of resources on our website. I encourage you to go to the HCP resource that THT created. Also, here's the website to support our partners in the Ukraine. So thrilled you're all here. There's so many numbers of people here that are helping us change what it means to live and love with HIV around the world. Thank you.
Thank you, Bruce. Wonderful as always, and thank you for your continued powerful activism. The energy and the drive that you have put behind this campaign over the last nearly 6 years more is remarkable, and we're all very grateful for all of your efforts. So we've now reached the Q&A time. So I can see all of our panelists have come back. Thank you for that. All cameras are on. Now we have a few questions in the Q&A already. One, Bruce, you've already kindly answered, which was some use the term effectively zero. Is this needed? I don't know if anybody else wants to say anything else about that, but we've got really powerful statements. Zero risks, zero excuses, and the time of vague language like effectively zero, negligible, low risk, may prevent, might reduce the risk are well behind us. Definitive language is essential in this. I don't know if you wanted to say anything else about that, Bruce or Alison. No.
No, completely agree.
Okay, so in no particular order, and I might take them in a slightly different order from when they came in, but we'll certainly get time to ask everybody's questions. I'm going to come to you, Alison. Something that you often talk about, and you mentioned in your talk, the yes buts, the areas where people have perhaps some concern. So there's a question from Carolyn. I'm going to sort of paraphrase a little bit, if I may. Is there evidence that if the viral load is undetectable, then the virus cannot be transmitted through needle stick injury? So I might just expand that and ask you to talk to what can we say, or what does U equals U apply in non-sexual settings like needle stick injuries?
Yeah, I mean, all of the evidence is in sexual transmission. That was a question we wanted to answer. So with a research study, you get a question and you answer it. So we know, as I said, that viral load is strongly associated with risk of transmission. If you suppress and you inject drugs, your risk will be dramatically reduced. But we don't have the evidence to say it's zero. So U equals U is around sexual transmission. And I think it's such a clear, definitive message that, yeah, that's the message. So we know it reduces it in other areas like maternal to child or injecting drugs, but all the evidence that we've put together over the last 20 years is around sexual transmission.
Thanks, Alison. I think, as you said, it doesn't take away from the fact that we can be very, very reassuring about transmission risk in other settings. An undetectable viral load does dramatically reduce the risk. And the other setting we often get asked about is breastfeeding as well. So U equals U applies to sexual transmission, but we can still talk very positively about the positive impacts on transmission in other settings. I'm going to go to the definition of U equals U. This is another one, perhaps we'll start with you, Alison. How do we define U equals U? The specific question is, less than 200 equals U is not as catchy as U equals U, but is that what we actually mean? Different labs have different lower limits of detectability of a viral load. What should our messaging be?
Yeah, it's U equals U. We chose less than 200 to basically align with all the other studies in this area. And it gives you a little bit of room as well if you slightly transiently blip up and resuppress. So it's less than 200. If you're less than 200, U equals U applies. And it doesn't depend on the lower limit of the lab, with down to 20 in many labs. But yeah, I think so. U equals U, but it's just understanding that's what all the studies use. And it's quite reassuring, I think, that people understand that that was the limit and that's where all the evidence applies.
Great. I'm going to come to Mel now, if I may, Mel, for this question, and then perhaps some other thoughts around how we can improve perhaps perhaps from an HIV setting, whether that's community organisations or HIV specialist services, improve our communication with primary care to support this message. So the specific question is, should you be something we put on all clinic letters and referrals like we do with drug interactions, and perhaps with reference to the THT training resource?
I think the short answer to that is yes, I think it should be. I think, just like Alison said, you know, that researchers are cautious, science is cautious, and I think GPs are cautious. I think probably as a specialty, we're a bit less cautious than some of our other colleagues, because a lot of what we do is about manage risk. However, having said that, GPs are used to hedging. We're used to hedging our bets. So we'll say, look, I think from your symptoms, it's highly unlikely you have a brain tumor. It's highly unlikely you have this. You're trying to reassure people all of the time, but it's less common for us to say never. You know, at the back of our mind, we've all had this scare story, you know, or we've had that one patient one time where the headache really was a brain tumor. So we're talking about risk all the time. We're managing risk all the time. We're used to that. But I don't think it's natural for us to say this never happens. This will not happen. If you're undetectable, if your viral load is undetectable, you will not transmit. That's a change in what we're sort of how we usually practice. And I think the more that can be supported, the more we can support each other. You know, there will be some people who need to hear it from, you know, Michael Brady, and that's who they need to hear it from, and I can't do anything about that. But there'll be some people who actually will, you know, prefer to hear or believe the message more when it's actually like just their GP round the corner who's known them for 10 years, knows their family, who says, yeah, no, this is true. This is not something slick and, you know, something corporate. This is true, and I believe this, and this is what I tell all my patients. So I think we just kind of need to work in partnership. But in answer to the question about the letter, yes, I think it should. I think it should be. It's an easy thing to add to letters. We get some letters which have the stuff about from certain clinics about interacting drugs, and, you know, call this number to speak to a pharmacist, and that's all super useful. And I think as a specialty, you know, HIV clinics have a great reputation. You know, we know our colleagues to be friendly. We know we can pick up the phone and just discuss a patient, or if someone's been diagnosed and we're a bit panicky about the result and what do we say, you know we can call our HIV clinics. And so I think in that vein, absolutely just splash the message on letters as well. It will help with the general kind of shift and the general moving people in the right direction.
Thanks, Mel. Just to give you a heads up, Estelle, I'm going to come to you if I may, because I think there's also something that Mel touched on there that you touched on during your talk, and this I think is about the importance of having different sources of information and recognizing that different individuals will hear the message better from different sources, whether that's Dr. Michael Brady or whether that's Bruce or Alison or Mel or a healthcare professional, and actually recognizing as healthcare professionals that sometimes we aren't the right people to give the message, and we're not always, it's not best heard from us always. So Estelle, do you want to say a little bit about that? Perhaps thinking about your work as a peer mentor and a mother mentor, and the importance of perhaps getting the message from other directions, not just the doctor.
Yes, yeah, that's a very important question, because I work with different community, and mainly women from Black ethnic minority, and some you can find like there's some challenges sometimes in terms of how do I, because we do try and get this message to them, to the community, but there's still a few that really want it explained in a way that they can understand. And if there could be some information that's easy to understand, maybe in a clinic setting, or maybe by the GP, something that is easier in terms of the way it's written, so that we can probably use it in our, when we are peer mentoring in our organization, because it does get quite difficult, and You know, I know sometimes we do go out to the churches, you know, faith leaders, and they sit us down and do ask a lot of questions. And sometimes, you know, we don't want to be, oh, we don't know, but, you know, so if there was a way we can also get some training in how do we work with faith leaders, because they are really important. The faith leaders are the key people to get the information of U is equals to U, and to get the community testing, especially the Black ethnic minority. So sometimes we just find the challenges in terms of how do we discuss, how do we talk to these people. If we could maybe get some better training to get how to share this knowledge with our community.
Thanks, Estelle. Next question, I might come to Bruce first, but anyone else feel free to chip in. Is there any evidence that knowing about U equals U improves other health or engagement outcomes?
Oh, yes, there's excellent evidence from the PP2 Positive Perspectives Wave 2 study. It was a study in 25 countries that showed that when people living with HIV were informed by their healthcare providers about U equals U, they showed significantly, or they reported significantly more improved mental health, sexual health, overall health, viral suppression rates, comfort sharing their status, and adherence. So this is really important data to show that it does improve the health outcomes of people living with HIV when healthcare professionals inform us about U equals U. That's a great question.
Thanks, Bruce. There's also a study in South Africa, actually, where they randomized a setting where they had outreach for men, particularly to encourage HIV testing, and they randomized some days to tell them about U equals U and some days not to tell them about U equals U, and had a significant increase in the number of men coming forward for HIV testing in that setting on the days when they talked about U equals U. So it's a powerful message to drive testing as well. Perhaps a quick one. I'm going to come to Alison for this. Some have asked my team if U equals U will still apply if someone stops taking antiretrovirals. We outline how U equals U works, but do we know how long it would take for stopping meds to impact on viral load?
Yeah, everyone's different. So if you've been suppressed for a long time, it can take quite a significant period of time to go above 200. Everyone's different, but the key is, as Bruce said, is it's helping people to stay on treatment. So that's the key to U equals U, it's adherence. If you're able to take your meds, you'll stay under 200 and U equals U applies. So I think that's the key thing as well, which was lovely to see that slide that Bruce had about all the areas that U equals U impacts on. And it's really just trying to support people to live healthy lives. And you want to stay on ART for other reasons too. It's not just about transmission, it's about your own health too. So I think that's key. And it was lovely to see that being your sort of third area of focus at the moment. Thanks.
Thanks, Alison. So before I come to the panel for some closing thoughts, let's see if we've got a couple of questions which are in a similar vein from Tom. Let's see if we can try and wrap these together. The evidence on U equals U is really clear and incontrovertible at this point. What do we need to do next to continue to translate the evidence into a social movement for change that tackles barriers and challenges stigmas? And perhaps if we can consider within that, how do we influence those in power? And who should we be seeking to do this with? Bruce, I think you might be the expert on this, but we'll come to you first and then see if others have.
Join us. Come to the website and sign on and join the U equals U movement. And we train activists and advocates. We have an incredible community leadership board of the best, most incredible activists you can meet from every continent who are pushing U equals U. So if you can join us, we can give you some strategies and ideas. My email is bruce@preventionaccess.org, and I'd be happy to connect whoever is interested and whoever wrote that question.
Thanks, Bruce. One of the many reasons to have a look on the Prevention Access website, which does have really great resources. It's also a useful resource if you're working with people for whom English is not their first language. Quite a lot of our resources, certainly in the UK, are unfortunately mostly in English, but you can find things through those global networks that may actually better communicate with your patients if English isn't their first language. Okay, I think, did I just see another question pop up? I think we're going to move towards the end. We've got about 7 minutes left, and I want to come back to all of our panel one by one for a take-home message to send you all off into your evenings with. We'll perhaps, no, let's do it in reverse order. No, I'm going to do it in a different, yeah, I'm going to do it in a different order. I'm going to come to Bruce first, and then Alison, and then Mel, and then I'm going to come back to Sue and Dean and Estelle. So Bruce, what would be your take-home message that you'd like people to take home?
Okay, I think, well, the take-home message is that we know change is hard. Resistance to change is human nature. And we've been talking about HIV transmission and people with HIV for so long, for decades, in a very radical way from U equals U. So it's just so important to understand that this resistance to talking about U equals U, you might know it, but then actually telling people is uncomfortable and it's scary. And so one thing we like to tell people is trust the experts, borrow confidence from the expert. When you find yourself resisting talking about it, and a lot of people just do because it's so new, borrow confidence from people like Alison, from the WHO, from the CDC, and you can have, and BIVA, you can have faith that it's true, it's real, and it's so important to share with people with HIV and those affected by HIV.
Thanks, Bruce. Alison.
Gosh, they were like following Bruce. What do you say? I just think, I mean, it's not underestimating the power of the campaign. I mean, it is transformative in so many areas of people living with HIV, their lives. And I think it's such a good news story. I mean, I tend to approach it as such a powerful, positive thing in a time when actually you don't get much good news. This is a really good news story, and it's spreading that and having the confidence. It's really just having the confidence. There's no yes buts. There's nothing. The data's there. It's indisputable. And the power of U equals U is quite phenomenal. Thanks.
Mel.
Yeah, very similar. I mean, I think my message would really be to healthcare professionals that we have a responsibility to talk about U equals U. I think if you're ever talking about HIV, you should couple that with U equals U. You shouldn't really be talking about HIV, whether that's offering a test or talking about someone who has HIV, who who's living with HIV, and you're talking about their care. Whether in either scenario, I think if we're talking about HIV, it's important to couple it to U equals U, because otherwise we're not talking about the condition in a way that people kind of can understand the reality of how fantastic the treatment is and what it means for ending stigma. So I think that we have a responsibility to do this. I think that it's actually an honor to do this and to be involved in this. I mean, all the hard work's been done by the scientists and the activists. If we're on the front line and we're having conversations with our patients, we can be very assured by the fact that of the quality of the overwhelming evidence and the transformative impact it has. So actually, what an honor to have these conversations, and we should just get on and do it and spread the good news.
Thanks, Mel. Dean, what would your take-home message, final thought be?
Thank you. I would say one thing I forgot to mention. I was unfortunate enough to have actually passed on HIV to someone prior to treatment, and I can't even begin to explain the pain, the guilt. Yeah, okay, he's on treatment now and he's fine, but the pain and the guilt and the hurt between it was my best friend as well. We just fooled around a bit. If U equals U could prevent that, then I would implore anyone watching just to crowbar it into anywhere possible. Just wedge it in, put a poster up, put a sticker up, give someone a leaflet, just raise it in conversation. Just that stigma, that's, to me, that's the killer. Medicine sorts me out, but this stigma is a lot harder to deal with. So yeah, I would just say, just crowbar it in any way you can.
Crowbar it in, great advice. Estelle. You're on mute, Estelle.
Continue to educate, more meaningful involvement, more peer mentoring, more getting people involved. And I can't wait to see that movement working from North London to South London or to Buckingham Palace with our T-shirts and our whatever, just marching and sharing this U is equals to you. So people can really start asking, what is that? What does that mean? We need to do the movement. I cannot wait. Bruce, we need that movement. Yes.
Thanks, Estelle. And Sue, what would your take-home message be?
Okay, so take it from me as a woman living with HIV. I speak to young people, not just young people, other people that possibly could be at risk of HIV. They really want you to have that conversation with them because they want to hear their doctors talk to them about U equals you. You know, they really want that conversation with you. So empower yourself to, you know, put your head above the pulpit. They really want those conversations. Trust me, I speak to people every day about potential risk and, you know, oh, we're not sure, you know, so someone at a level that knows about U equals you, you know, again, like I said before, we're talking about the future of HIV, of ending stigma, ending the HIV transmission. That it has to stop with conversations. It always has to stop with conversations.
Thank you, Sue. A great way to bring this session to an end. It just remains for me to thank all of our contributors, all of our amazing speakers, to encourage all of you, thank all of you for attending and engaging and contributing, encouraging you to keep doing the work to spread the message about you. Have a look at the resources that are available on the THT website. A couple of other things. I need to thank Gilead Sciences for funding this work. It was all made possible by a grant from them. And please evaluate this session. This is part of a series of webinars that HIV Prevention England runs, and we'd be really keen and pleased to hear your feedback and any suggestions for future events. The team have put a link in the chat for the online evaluation form. So thanks again to everybody for coming, and particular thanks for all of our amazing contributors. I hope you enjoy the rest of your evening. Bye everyone.